management to host this meeting. So I'm going to start with the shorter topic, which is cervical cerclage and its indications, while antepartum hemorrhage will come second for sake of time. So the topic I'm starting with is cervical cerclage and its indications. For cervical cerclage, the major indication or the only indication is actually suspected cervical incompetence. It remains the most acceptable indication so far. But firstly, we have to define what cervical incompetence is. Cervical incompetence is the painless dilation of endocervical canal in pregnancy before the onset of labor. Its incidence is estimated to complicate about less than 2% of all pregnancies worldwide. It is thought to be responsible for approximately 15% of habitual immature deliveries between 16 and 28 weeks gestation. In most cases, the etiology is unknown. But when we have known causes include congenital weakness of the cervix itself, as in Mullerian abnormalities where we have cervical hypoplasia, and in utero, if the mom of the said lady took DES, which is diacylstilberol. Other known causes might be traumatic abnormalities from previous surgeries or previous obstetric trauma, like a lady in a previous delivery, like a lady that went for an illicit abortion and had a dilatation and curettage done. Other abnormalities include connective tissue disorders like Ehlers-Danlos syndrome. It's important to know that despite the advances in modern obstetrics, cervical incompetence diagnosis is more or less a controversy. There is no actual precise, for the diagnosis of cervical incompetence, there's no actual precise method of diagnosis. The strongest evidence of diagnosis include, for instance, when there's a lack of other causes of recurrent miscarriages. A lady has had more than 3 miscarriages and we have ruled out every other cause like an infection, a urinary tract infection, endocrine abnormalities, like diabetes before she became pregnant, chromosomal abnormalities. That's the #1 cause attributed for recurrent miscarriages, especially in the first trimester. The second would be previous history that is consistent with cervical incompetence. That means this woman has a previous history of a premature preterm premature rupture of membrane. She has had a previous cervical cerclage. She's had recurrent miscarriages, usually more than 3. Then also conditions that will predispose a lady to preterm labor in the current pregnancy, or she's had a history of preterm labor in the past. Conditions that predispose to preterm labor include multiple gestation, twinning, and triplets. Then also favorable pre-pregnancy risk factors. A lady could actually have cervical incompetence before she's even pregnant. But that will be demonstrable by presence of cervical funneling or shortening on hysterosalpingogram, or the lady has had recurrent abortions, this time voluntary, not spontaneous, where she severally had to use dilators to do the process. For instance, if a lady coming to your clinic comes for an abortion and all that, and the cervix is so free that it permits Hegar dilators more than size 8 and above, you know that this lady in the nearest future may be prone to cervical incompetence, and she's a candidate for cerclage. Then also, as we said, if the lady has an extensive history of surgical trauma to the cervix or obstetric trauma to the cervix, examples, like I said, from illicit abortions from D and C, that's dilatation and curettage. The indications for cervical incompetence are broken down into three. Prophylactic cerclage. This is where, because of the woman's previous obstetric history, you want to do this just to prevent any untoward loss of pregnancy, especially in the second trimester, in the early second trimester, or even in the late second trimester. So usually this is done within 10 to 15 weeks for the lady. That's why it's called prophylactic. It's based on the woman's history. You're trying to do this. Other indications include the urgent cerclage. This is usually diagnosed via ultrasound. The lady is asymptomatic. She's presenting in your office. It's not like there's a previous history in this woman, but you notice via an ultrasound that she's having, the cervix seems very short. The length of the cervix seems very, very short. This is the kind of woman you offer an urgent cerclage. Then the third indication is usually the rescue or salvage cerclage. In this case, the woman may be presenting to you with bulging membranes per vagina. You do a speculum exam and you see this woman with membranes bulging. Note, a rescue cerclage is usually done before 28 weeks. It can't be done after. At that point in time, because in Nigeria, 28 weeks is regarded as date of viability. That means the fetus can actually live outside the mom's womb at that point in time. A rescue cerclage should not be done once one of the following has occurred. If the woman has now eventually ruptured membrane, or you notice via the scan that the fetus has some abnormalities that are not compatible with life. Examples, anencephaly, the child was born with no brain matter, for instance, or the child via scan, you saw that there was no brain matter, so rather. Chorioamnitis, that's an infection of the gestational sac, basically. Or there has been uterine bleeding, or uterine contractions are set in to start a preterm labor. You can't do a rescue cerclage. Before a cerclage is done, some evaluations are usually done for the woman. You've taken, after taking your history into account, why she's had recurrent miscarriages in the past, then you've used an ultrasound to confirm that the fetus is compatible with life. Then before you even take the woman to theater, you also have to do an endocervical swab to rule out these organisms, infections from these organisms. Gonorrhea, chlamydia, or group B streptococcus. Their culture must be taken and it must be shown negative before you go ahead. If not, you must treat. If you see candidiasis there, you treat before you go ahead with your cerclage. Then lastly, the patient should be counseled that no sexual intercourse 1 week before and after the procedure. Then cerclage itself. As I said, cerclage could be done, cerclage itself could be done before pregnancy or even after the woman has taken in. For those that is before pregnancy, it's not very common in this environment. We've noticed that the woman she meets the criteria for cervical incompetence, which we've discussed before. And thus we offer her a cervical cerclage. An example, this woman has had extensive surgical procedures in that area in the past, or obstetric procedures in the past. So she's the kind of candidate you offer a lash cerclage. Then after she's pregnant, it's either she gets a transvaginal cerclage or a transabdominal. What is commonly done in our center is a transvaginal cerclage. Examples of transvaginal cerclage are the McDonald's and Shirodka. While for transabdominal cerclage, it's more or less cervical isthmic, a cervical isthmic procedure that's done. the examples of McDonald, usually, I'm not going to dwell too much on the procedure itself, how it looks like. It's usually a posturing that's done for McDonald's. The posturing stitch that is done is usually at the cervical vaginal region for McDonald. Then for Shiroka, it's a bit higher. With every surgical procedure, there are complications. So cervical cerclage itself has its own complications as well. Examples include premature rupture of membrane. This complicates between 9% of most cervical cerclages. Then chorioamnitis itself. This complicates about 7% of cervical cerclage procedures. If the cervix is more than 3 cm dilated, then a cervical cerclage should not be attempted, because if you attempt it, you increase the risk of chorioamnitis. Also, if preterm labor has been established, the woman has started having contractions. If you can look back at the former slide where I listed where a rescue cerclage should not be done. If preterm labor has, that's uterine contractions have already started, she has probably ruptured membrane, and this woman is less than the age of viability in pregnancy, it should not be attempted. A cervical cerclage shouldn't be attempted because it increases the risk of complications. Cervical laceration or amputation, that may be from previous obstetric surgeries or procedures. Then a bladder injury. Though this is rare, but this could happen, especially with the Shirodka technique. Then cervical dystocia, if the woman has had a previous dilatation and curettage, and now she has narrowing of the cervix. This as well could be a complication from cervical cerclage, because by the time you put the post tubing, the place heals by the post tubing stitch, it heals by fibrosis, and that might narrow the cervix subsequently. So most times the child or the fetus is delivered by cesarean section in most cases, so that because there's this risk of cervical dystocia, also bleeding, as with any surgical procedure, bleeding is a complication. Then uterine rupture, which is rare. In summary, cervical cerclage does not guarantee 100% the prevention of pregnancy loss. But however, it prolongs pregnancy on the average by 5 weeks from when the termination would have occurred. Thus, it's highly beneficial in women at risk of cervical incompetence. I will go to our next topic, which is the first topic that I started from the back, the last topic. The first topic is Antepartum hemorrhage. So I would like to tell you what Antepartum hemorrhage is. Antepartum hemorrhage is actually death from hemorrhage. When I use the term hemorrhage, I'm referring to when I use the term hemorrhage, I'm referring to bleeding. I could use them interchangeably, please. So antepartum hemorrhage refers to a death that, hemorrhage rather, or bleeding, is the leading cause of maternal mortality in our environment. Antepartum hemorrhage is defined as bleeding from the genital tract in pregnancy from the age of viability. WHO, that's around the world with better healthcare techniques and procedures, call age of viability, where the fetus can live outside the mother's womb at 24 weeks. But in Nigeria, we operate by 28 weeks. So antepartum hemorrhage, which I shortened as APH, is defined as Antepartum hemorrhage, which is APH, is defined as bleeding from the genital tract of a woman in pregnancy from the age of viability, and this is before the onset of labor. Age of viability before the onset of labor. It affects about 4% of all pregnancies, and it is a medical emergency. It is associated with increased risk to the fetus and to the mom. The causes, I did a little diagram to show you the causes of antepartum hemorrhage. 70% of antepartum hemorrhage is from the placenta. The bleeding is occurring from the placenta, which is now divided into placenta previa and abruptio, which is our main topics for today. We'll dwell a lot on these topics. Then 25% might be unexplained or indeterminate bleeding. That means we have excluded blood loss from the placenta, and we think the bleeding is coming from local lesions. Maybe the woman has a coexisting cervical polyp or fibroid in pregnancy. So that might be responsible for the 25%. Then extra placental causes, you can see 5%, as you can see listed. Cervical polyp, carcinoma cervix, or cancer of the cervix, a varicose vein, local trauma. That means maybe the woman, for some reason, it caused some form of injury to herself. So we'll start with placenta previa. Since under the causes of antepartum hemorrhage, 70% is from placenta bleeding. That's where we'll dwell most of this topic on. Placenta previa. Placenta previa is usually defined as the implantation of the placenta partially or wholly in the lower uterine segment. About one-third. Could you mute your...
Do you want to share your...
About 1/3 of cases of antepartum hemorrhage belong to placenta previa. So we're going to dwell a lot, as I said, on this area. The incidence of placenta previa is usually less than 1% amongst hospital deliveries. In 80% of those cases of placenta previa, they are usually found in multiparous women, women that have given birth more than once. The etiology of placenta previa, usually the exact cause for why the placenta will go and implant in the lower uterine segment, most of the times is not known. But there are some risk factors that we've come up with. We've seen that this placenta previa is common in these women with these risk factors. An elderly primary gravida, or a woman giving birth for the first time with an advanced age, a lady giving birth for the first time more than 40 years, a woman that's given birth more than once, previous cesarean delivery, a lady that's smoking, or a lady that smokes. Reason being, smoking would mess up the placenta vessel implantation into the womb. Then for previous cesarean delivery, the lower uterine segment may have healed by fibrosis. So during placenta implantation, it will have to look for somewhere, the placenta will have to implant, since that area healed by fibrosis will now implant on it. So that's why a risk of previous cesarean delivery is there. Then also, if you've had a placenta previa in the past, there's all likelihood you could have it again. Then structural abnormalities in the womb as well. Then assisted reproductive techniques. Reason being, assisted reproductive techniques lead to multiple gestations and when there's more than 2 placentas in the womb, basically, they'll have to struggle for where to implant, and they could implant at the lower uterine segment. So for placenta previa, it has different degrees. Usually it's classified as type 1 to 4 or degrees 1 to 4. As you can see on the screen, we have type 1, which is the low lying. The placenta edge is at the lower uterine segment, but it does not get to the internal os. Then we also have the type 2, we usually call that marginal. It reaches the margin of the internal os, but it does not cover it. For the type 1, it's usually 2 centimeters away from the margin of the internal os, but it is low lying. Then for type 3 can either be incomplete, it's called incomplete, or partial. In the type 3, the placenta usually now covers the internal os of the cervix, but it does not completely close it. When the cervix dilates, it gives some gap. While in type 4, it's completely blocked. The placenta completely implants on the internal os of the cervix. I'll give you a few diagrams so that you can understand what I'm saying, so that it doesn't look vague. You can see
Doctor, please, your slide is not showing. No, your slide is not showing it here.
Okay. Can you see it now?
Yes, it's better. We can see.
Okay, you can see it now. Sorry about that. Do I go back a bit? Do I go back a bit, or we're okay from here?
We are okay.
Okay.
Fine.
Okay, so these are diagrams of what I was describing. For type 1, you can see that's the placenta. It's about 2 centimeters. That's the internal os, where that line is. That imaginary line you can see. That's the internal os that leads to the vagina. That's for type 1. Then for type 2, you can see it. It's at the margin of the internal os of the cervix. While for type 3, you can also see it. It partially covers it, but when the cervix expands, it shifts back a bit. While for type 4, there's complete blockage. You can see it resting on top of the internal os of the cervix. So how the bleeding usually occurs. This is just a little bit about the history of how the bleeding occurs. Usually it occurs from small or slight disruptions in the placenta attachment during the normal development. This is where smoking, women that smoke, it plays an important risk factor. Because the smoking is usually causes placenta abnormal development of these placenta vessels. So as the placenta grows, placenta growth usually slows down in the coming months, and the lower uterine segment dilates with expansion of the fetus and all that, the inelastic placenta is now shed off from the lower uterine segment, and this now leads to the bleeding that we see. So it's the signs, the clinical features. These are the signs you recognize as a lady that's already 28 weeks plus. These are the signs you recognize. First is usually bleeding. That's the most common sign we'll see. It's usually recurrent. It's painless. The woman doesn't feel pain. It's not like she's having any lower abdominal pain. If you examine her uterus is fine, her tummy is fine, she's not having any abdominal pain, but she's bleeding, and she's more than 28 weeks. Most times the fetal heart rate is usually fine. When you come in, you check the lady, the fetal heart rate is still fine. Unless the volume of blood is so much, that's when there will be a bit of fetal heart rate abnormalities. Then usually there will be malpresentation on examination. The baby will not be presenting cephalic most of the time. which is understandable because the place where its head was supposed to be, the placenta has now taken over that spot. So the baby will assume any other position. Either it will be presenting, its leg will be the presenting part, that means the leading part, or the baby will lie oblique, or the baby will lie transverse, just across in the middle of the mother's tummy. So when you examine the woman's tummy, these are the things you will see. As I said, apart from the malpresentation, that means the baby did not assume the normal cephalic presentation, presenting with its head. It assumed another position. Then, even if the baby is presenting with his head, the head will be high up because it's understandable. The lower uterine segment where we would have felt the head, the placenta has taken that spot. So the baby's head will be high up. And even when you're listening to the fetal heart sound, everything will be high up. Most times, usually above the umbilicus of the woman. Then on inspection of the vulva and the vagina, you usually see bright red blood, which is to say that she's actively bleeding. But most times, vaginal examination is usually contraindicated. Apart from the history that the woman presents with, a scan is the best way to confirm your diagnosis. So the best thing a scan will show you, these are the examples of scans, the best kind of scans to use to diagnose this. The normal obstetrics and use the transabdominal ultrasound, then the transvaginal ultrasound, transperineal, as we can see above, as listed above. Then also during delivery of the baby, you also see the implantation of the placenta. You see the location of the placenta. So the management, let's go quickly to the management. Ideally, placenta previa is best prevented than it actually occurring in pregnancy. That's the whole essence of the antenatal, where women are constantly monitored to see the location of the placenta via an ultrasound scan to see if we are going to anticipate this kind of risk later on along the pregnancy. So it's usually best prevented than it occurring. Then when it's paraventure, it now occurs. The treatment is usually on admission. You admit the woman. It's a regimen they usually call McAfee regimen. You admit the woman and constantly monitor till delivery is certain. So these are just steps that you do during the admission process. So usually, what is usually done is, if this woman presents to you at 28 weeks, after admitting the woman, you don't say, you want to go and section the woman as quick as possible. It's unless there's a fetal compromise, you think of sectioning the woman. But if there's no fetal compromise, it's best as possible to wait till the lungs are mature, which is usually at 34 weeks. So paraventure, this woman presents to you at 28 weeks. The idea is to keep on managing and monitoring her till 34 weeks. She will have to be on admission with you in the hospital. That's the whole process of the whole idea of the McAfee regimen. You can see, as you can see, strict bed rest. The woman will be on strict bed rest. Investigations will be done. Then you will periodically be monitoring. This is the vital part of the admission. Periodically be monitoring the vulvar pads. Is she still actively bleeding? Then fetal surveillance. That's with a scan and also a fetal Doppler to see that the fetal heart rate is still present or there's no fetal compromise. Then peradventure, you keep doing expectant management to before 34 weeks. You can see what is usually given. If there's now a fetal compromise, you now have to give steroids for long maturation before 34 weeks of age. As much as possible, if this woman is now having abdominal pain or uterine contractions, you have to give some form of tocolytics, medications that will slow these contractions or ultimately abort them. Then part of the investigations run are the resource immunoglobulin to find out if, for instance, if the mother during the antenatal screening process is A negative, for instance, and the husband is O positive, the woman needs to be screened as well, especially if this is not the first time. You know, I said it's common in multiparous women that has given birth before. This screening, that's the essence of the antenatal screening. This will be taken into consideration and certain medications or things will be given so that the fetus doesn't die in utero or doesn't die in the womb, I mean. So active management, we've left the expectant part of the management. We're now at the active management. Okay, bleeding occurs at or after 37 weeks of pregnancy. You know, I said it starts, that's what classifies it as antepartum hemorrhage. It starts from 28 weeks. Then the patient is in labor. There's now fetal distress. Or she's bleeding profusely. Then or you notice via your scan that the baby has an abnormality that is not compatible with life. Or you notice peradventure the baby has died in utero while the woman is presenting to you. So cesarean section is done for all women with sonographic evidence of placenta previa, especially where the placenta edge is within 2 cm from the internal cervical os. It is especially indicated if the placenta is posterior, the placenta location. So this is just an example of the scheme of management so far of placenta previa in the hospital. Can we all see it? It's just a summary. This is just a summary of all what I've been saying, basically. All placenta previa patients, APH patients, are to be admitted. Once they present to you, as we said, it's a medical emergency, so these patients are admitted. So these are just the list of things that will be done for the patient. It's either then, once the patient is admitted, is to determine if it's an expectant management process you're going to follow, the McAfee regimen, or an active interference. That means the bleeding is so severe, the pregnancy is more than 37 weeks. That means the baby is already term, so you can deliver. There's no contraindication for delivery. Unlike under expectant management, you can see it. Pregnancy is less than 37 weeks, most times even less than 34 weeks. It's even less than 34 weeks. But the patient is hemodynamically stable. That means she's not bleeding profusely. Sometimes she's not even bleeding anymore. She may have had a history of bleeding at home before presenting. Irrespective, you have to monitor the patient and see. So this is just an algorithm of what's going on. Either there's an expectant management, the McAfee regimen, or an active interference. So the complications of placenta previa. We usually divide the complications into maternal and fetal. That means complications to the mother, complications to the baby, basically. There's the risk, the woman runs the risk of preterm labor. Already, I told you in the presentation, I told you earlier that on examination, the doctor most times will find that the baby is not in the right presentation, is not presenting with the head. And even if the baby is presenting with the head will still be high up. Then the risk the lady runs during labor, this is during the pregnancy, under the maternal complication is divided during pregnancy, then during labor, then even after delivery. So we can see the complications as listed above. During labor, she runs the risk of a premature rupture of membrane, a cord prolapse, bleeding profusely during the labor itself, because once because the placenta is usually attached to the uterus and it has a rich blood supply, very rich blood supply. If this bleeding is not arrested, it could lead to shock, which is the last of the intrapartum complications. Then APH itself can predispose the woman to postpartum hemorrhage. That means after delivery of the fetus, she keeps bleeding and all that. Then the placenta itself could be retained because it has so embedded into the lining of the womb or the uterus. It has decided to become one with it. Then these things also predispose the woman to infection, and the womb, the size of the uterus won't go back to its normal size because the uterus didn't properly contract well. But that's the essence. These are just the complications that could arise. But all these most times are mitigated in the hospital because we are aware these kind of things will happen and we take steps to prevent them. So women or children born to women with diagnosed with APH, they run the risk of having a low birth weight because they didn't actually grow. The placenta occupied some part of the womb where the baby would have used to grow and expand. Then there's also the risk of birth injuries and the baby could die in utero, could die in the womb. The next topic under antepartum hemorrhage is placenta abruptio. This is even much more concern than placenta previa. Though placenta previa among the placenta causes of antepartum hemorrhage is the most commoner, but placenta abruptio placenta, if it occurs, is much more dire or threatening. It is one form of antepartum hemorrhage where the bleeding occurs due to premature separation of a normally situated placenta after the age of viability. That means this woman presents to you above 28 weeks gestational age. Then for some reason, she comes in with very sharp pain and you notice that the womb and profuse bleeding, sharp abdominal pain and profuse bleeding. The difference here is that you can see the placenta is normally located. Nothing was wrong with the location of the placenta. It's not like it's embedded at the lower uterine segment in this point in time. For some reason, the placenta separates. We'll give you reasons why. It occurs in about 2% of all pregnancies worldwide. And the mortality, perinatal mortality, that means it carries a very great risk to the child. You can see 119 deaths per 1,000 babies. Per 1,000 births that were seen to have placenta abruptio or abruptio placentae, about 119, there was nothing anybody could do. So it's much more dire an emergency than placenta previa. It needs active management. So these are examples of the types of placenta abruptio or abruptio placentae with diagrams. Can you see the diagrams? So I'll just briefly run through them. We have the reveal type, which I'll show you down with the diagram. Here, the blood, the bleeding, you actually can see through the cervical canal. The woman comes to you and she's pouring. She says, "I'm bleeding, doc." Then occasionally, placenta abruptio may be concealed. Or it could be a combination of both. That means sometimes the woman is bleeding a bit, then she's still having severe and intense abdominal pains. So it's a mixture of bits, it's a bit concealed and some part is still seen. So you can see the diagram. You can see where the placenta is normally located. Then that's the bleeding. For some reason, the separation has occurred. This is the concealed type. And you won't see the woman pouring per vagina, but there's still ways we can find out from physical examination. Then this is the revealed type, where you can see the separation has occurred, normally situated placenta, and the blood starts flowing through the cervical canal to the vagina. Then this is marginal. Placenta separation has occurred, but it's still a bit congealed. Then you can see pre-placental. It didn't actually occur here, but it's like there's hematoma already forming, or a collection of blood forming already in the placenta itself. So these are the clinical classifications of placenta abruptio or abruptio placentae. It means the same thing. I just put one before the other. So grade 0, that means the woman doesn't really present with symptoms. So it's after delivery, you may even get to find out that, oh, placenta has actually shed because of the profuse bleeding that followed after the delivery of the baby. Then in grade 1, which occurs in about 40%, there's vaginal bleeding. Then if you touch the woman's tummy, she's very irritable. In fact, there's something that's, there's a particular sign that qualifies it. When you try to examine her tummy, the tummy is woody hard. It's hard like a tabletop. That's how hard the woman's tummy is. So these are the grades or classifications. The grade 3 is the one where the woman comes in shock. Most times the baby is even dead at that point in time. And the internal clotting process of the body, that's the associated coagulation defects, would have already set in. And if at that point in time, active management needs to, or active interference needs to be done. Clotting factors, urgent blood transfusion and all that to save the woman's life. It's not anymore a case of trying to save the baby, because the baby already at this grade 3 would have been dead. So these are risk factors that predispose a woman to placenta abruptio. A woman that has high blood pressure that has not been well controlled prior to pregnancy. Preeclampsia itself predisposes a woman to placenta abruptio. I'll just briefly give a background definition of preeclampsia. Usually, preeclampsia is pregnancy-induced hypertension with proteinuria. This pregnancy-induced hypertension is high blood pressure noticed in pregnancy from 20 weeks of gestation in pregnancy that may persist to even 6 weeks after delivery. That's basically the definition of pregnancy-induced hypertension. So preeclampsia is now that pregnancy-induced hypertension plus proteinuria, protein in urine. So that's basically preeclampsia. So it predisposes itself. At 20 weeks in pregnancy, this woman was noticed. That's the essence of the whole antenatal process, so that you keep on monitoring. Okay, this woman was noticed to have elevated blood pressure and protein in urine. What keeps running through your mind is, would this woman be at risk of placenta abruptio? So that's why preeclampsia itself needs to be taken care of. And chronic hypertension, a woman that was hypertensive before pregnancy. Then other risk factors, as we can see. preterm rupture of membrane, multiple gestation, that is twinning, and what have you. Cigarette smoking, it's usually folic acid deficiency. You can see there are a lot of a uterine fibroid that will be struggling for blood supply with the placenta. That's a massive uterine fibroid, not a tiny one per se. But 3/4 of the times, just like placenta previa, nobody actually knows the reason why this happens. But these are risk factors we just came up with because it has been seen in these women. These are the kind of risk factors. And it has been seen in all these women with these risk factors that they run the risk of having placenta abruptio. So for the clinical presentation, usually you can see as above, bleeding, which is the most significant presentation. Then worst case scenario, that was like the grade 3 I was talking about. The woman is already showing signs of shock. She's fainting and collapsed. In fact, the woman will be barely with you, maybe drifting in and out of consciousness. Then this is what I was talking about, the woody, hard, tender tummy. The woman's tummy is as hard as wood, and at the same time, she's in intense pain. Then this may be seen more or less in those that are fair skinned and all that, because there might be an accumulation of blood somewhere concealed. It's not every time the bleeding comes out, but you see the woody, hard tummy, then you see an accumulation of blood concealed. At that point in time, when you try to examine, you may not really be feeling the parts of the fetus, of the child or the fetus, and you may not even get a heart sound. So that's why it's usually an urgent emergency. As I said, it's much more dire. There's most times, in fact, there's no time for an expectant management. Unlike placenta previa, there's an expectant management phase. So usually the management depends on at what age of the pregnancy the woman is presenting and the status of the mother and the child. For instance, the woman is presenting at 28 weeks. You can't get a fetal heart rate. The woman is semi-comatose. It's best you save the woman's life, and you have to make a decision as the clinician at that point in time. Which life is more important? Then your findings and all that, then you have to immediately group and cross-match for blood, because this woman has been bleeding, you don't know how much. If while during assessment, initial assessment, you can't assess the fetal well-being, it's best you make a decision on whose life is more important to be salvaged at that point in time. So the principles of management, you can see early delivery at whatever cost. This is the principles of management, early delivery. You can see it. Adequate blood transfusion, because this woman has been bleeding profusely. Most times the blood will be concealed by the time the woman is coming in with a woody, hard tummy. Analgesia for the pain that she will be in, because you could barely touch that tummy. Most of these patients would have started having a coagulation abnormality, because the body, once there's a bleeding that occurs internally, the body would start the internal clotting process to stop that, to arrest that bleeding. So this has to be corrected. So look at a cesarean section will be offered as CS when the baby is distressed. Most times the baby is distressed in this condition, severe bleeding, and if the baby is alive. There are conditions in which during your initial assessment, you might not find that the baby is alive, but you still need to save the mother's life. So instead of taking a woman to theater to deliver a dead fetus, it's just best you do the normal conservation and let the woman expel per vagina than giving her a scarf for a dead baby. So if this woman, this is the only instance in our placenta abruptio, if this woman presents, she's hemodynamically stable, that means you cannot see any active bleeding. The usual presentation of abruptio is not usually seen, but you only diagnose it via a scan. That's when conservative management and giving steroids can be undertaken. But most of the times, a placenta abruptio is a very acute emergency that needs acute intervention at that point in time. You rarely find this kind of cases. You rarely find. Most of the time, it's an acute emergency. So this is just the scheme of management for placenta abruptio, just like how we saw with placenta previa as well. So the complications, most times, are usually an outcome of the clinical presentations the woman presents with. The complication, like if the woman is bleeding profusely, she'll go into shock. She'll come in cold extremities. Her pulse will be very weak and tready. You may not be really feeling the pulse and all that. She may be barely conscious enough to answer you. So as I said, because the woman is bleeding internally, the internal clotting process of the body would have taken place. So there will be clotting disorders. Then when the woman is in shock, definitely she will not be making enough urine and all that. Then they run the risk of infections. And if she's in shock, she's not making enough urine, it could lead to kidney damage and all, what have you. Then for the fetus, it's usually just like for placenta previa, IUGR, intrauterine growth restriction. These babies most times are small because they weren't getting enough blood supply. The placenta has already detached from the uterus. There was no more connection between the mother and the child anymore. Then most times, as I said, it's not every time. It starts from 28 weeks. So there's that risk of premature delivery. The child is not yet 10 and you have to deliver. Fetal distress, if you're lucky enough to feel the fetal heart rate and all that. So assess fetal well-being and all that, assess the heart rate. Most times the heart rate will be very high. Then the worst of all complications is death. So it's quite pertinent to distinguish between placenta previa and placenta abruptio. So these are just a few, These are just a few of the distinguishing factors. From the clinical presentation, you can see, even when the doctor is examining, usually in placenta previa, the woman bleeds, but it's painless. She just noticed, I'm bleeding. While in abruptio, she's in pain. The woman 3/4 of the times is in pain. You cannot touch the tummy, in fact. Then most times in abruptio, the clinical presentation you're meeting, if you meet the woman in shock, semi-comatose and all that, know that she has lost much more blood than what you're even thinking of replacing with. But in placenta previa is usually equivalent to such. Your clinical suspicion from the amount of blood loss that you're seeing will be proportionate to the patient you're seeing, to the clinical well-being of the patient you're seeing. Then you can see from examinations and all that. Well, these are majorly for the doctor. Then there's another small, very small area that also accounts for, though it's not very common, for bleeding or antepartum hemorrhage. That means bleeding from the genital tract from above 28 weeks gestational age. It's called Vasa Previa. In this scenario, it's more or less the fetal vessels, its attachment into the placenta. You can see it. The fetal vessels from the placenta cross the entrance to the birth canal. There's a kind of, the word is called filamentous insertion. The normal cord insertion of the fetus, the umbilical cord insertion to the placenta, the way it attaches to the birth, it now attaches to the birth canal in Vasa Previa, which is not supposed to be so. Its incidence is very little, 1 in 3,000 pregnancies, compared to abruptio and placenta previa. This itself is associated, the risk here is more or less to the child than the mother itself. It's associated with very high fetal mortality. You can see it, you can see the mortality rate between 50 to 95%. So this is an example. You can see filamentous insertion. You can see it. Filamentous insertion of the umbilical cord. So these are the 3 causes typically of the Vasa Previa. A bilobed placenta. That means the placenta somehow has 2 parts instead of 1 whole part. Then, as I said of before, the filamentous insertion of the umbilical cord. This is what we're talking about. This is an abnormal insertion of the umbilical cord and the umbilical vessels. So these are some of the risk factors. It has been seen that people with these risk factors are prone to placenta Vasa Previa. Multiple gestation, low-lying placenta. Low-lying placenta is basically Placenta Previa. Most likely a grade 1. Then pregnancies in vitro fertilization, IVF pregnancies to achieve multiple gestations. You see, they all roll hand in hand. Then when you feel palpable vessels, you can actually feel the umbilical cord of the baby during a vaginal examination, especially if the child is term or during delivery, the woman has entered labor. Usually it's asymptomatic. It's not like there's any warning beforehand, like Placenta Previa or Abruptio. There's really no warning beforehand. Sudden onset of painless bleeding in the 2nd or 3rd trimester, or at rupture of membranes. The woman is already in labor, she has presented during rupture of membrane. There might be no sign, though this may be risk factors, especially Placenta Previa, but there may be no sign of this during antenatal. You may also notice that this child is small. IUGR means intrauterine growth restriction. The child didn't achieve its certain growth potential. Usually at 28 weeks, I'll just add a little something there. Usually at 28 weeks, the child should have, the fetus should be about 1 kg. Then subsequently, it grows exponentially. So if by 28 weeks, we're not having an approximately 1 kg fetus, we start thinking of what's going wrong. Is there some form of intrauterine growth restriction? And from there, our mind starts to wander to these many possibilities. Then during the delivery process, the woman is in labor, membranes have been ruptured. You notice there's an abnormal fetal heart rate. The doctor noticed that the heart rate is not right. So basically, this is just a run through of the management. If the pregnancy is greater than 37 weeks, that means it's already 10, the best thing is to deliver. But the mode of delivery, you can see, it depends on the status of the fetus. As I said, the complication for Vasa Previa is more to the fetus. In fact, it's barest minimum to the mother. It's more to the fetus. Expectant management is usually done in select cases by the senior obstetrician. But if you notice, most times Vasa Previa is noticed during the delivery process. The woman is in labor, you have ruptured membranes, and you now notice Vasa Previa. Needs expeditious delivery, and the child needs to be transfused as urgently as possible. So I will say thank you for allowing me to have this opportunity to be your host today. And if there are any questions, please go ahead. Any questions? Any questions? Any questions?
Good morning, everybody.
Good morning.
Dr. Dogini, thank you so much for the presentation. God bless you.
Yes, sir.
Awesome stuff. Okay. Please, questions are coming in, so we'll try to answer as much questions as we can, either related to today's topic or any other topic. Okay. So this is Dr. Ikile. I see some questions already coming up. Okay, somebody said, Doctor, please, I'm having some serious catarrh and cough. Is there anything I can take? I told us the last time we should not make online consultations the thing. That is because it's always important for the doctor to examine you and do what? Run 1 or 2 tests. Or if I just assume that the catarrh and cough is just go take a cough syrup. What if it's more than that? So please go into the hospital, let the doctor examine your chest and take a look at you and make that decision. So please, Madam Faith, please go into the hospital and see any of the doctors on ground. They are on ground. And if need be, they will make a call to the gynecologist and carefully explain what the patient may be passing through. So thank you so much. Okay. And somebody else asked, is there a risk if my placenta location is posterior founder? Well, following the discussion he had with the Dr. Dogini had with us today, we see that the only problem we will have is if the placenta is doing what? Is close to the doorway, and I call the doorway the cervix. Imagine the room you are staying in right now is your womb, and the door you are going to pass out is your cervix. So anything that occupies close or to the doorway or covering the doorway is called a low-lying placenta or placenta previa, as the case may be. Okay, so any other place where the placenta is fine. We just don't want it close to that doorway. Okay? So your posterior fundal placenta is very fine, madam. So we have no issues with that. Okay. Somebody said, doctor, please, I've been having serious headache for 2 days now. I was at the hospital on Tuesday. I was giving anti-tetanus shot. I was giving a malaria drug. I was told to use 3 tablets at once. Okay, the 3 tablets we were given to use at once was a malaria prevention drug. It's not used to treat malaria, but to prevent malaria. Okay, so wait, now that you're having serious headache for 2 days, maybe you are going to this someone it has not done. I will implore you, go back into the hospital, let them run a malaria parasite test for you and run some other tests. And if need be, they will treat you now for malaria. What you were given was malaria prevention. Okay. Okay, did we get all that? Hello, everybody.
Yes, doctor.
Okay,
Good morning,
that is good.
Good morning,
That is
doctor.
good.
I have a question.
Good morning.
Okay, I was at the hospital last week, and I was tested positive for malaria, or I had malaria, and I've been having this cough since last 2 months. So the last test I had, I was told I had infection, so they gave me augmentin. So after a while, I got better. Then I went back for my normal antenatal care routine. That was last 2 weeks, and I did another test. So I still have the malaria, and I treated the malaria, but the cough is back. And I did test for the cough as well, but they said there was nothing there, that they can't give me anything because they didn't find anything in my. I did some tests, blood tests, urine tests, and saliva. I don't know what it's called, but saliva test as well. So the cough is back and the catarrh is back. I wasn't having catarrh before, but the catarrh started like 2 days ago. Although I got it from my son. My son can treat his own catarrh, but I can't treat mine. I've been using vitamin C, 1,000 milligrams, but it's still not getting better. So what do I do?
Okay,
I'm 4 weeks, 4 months pregnant.
Do you run your clinic in Ikeja or Mole?
Yes, sir. No, Ikeja, the one at Ikeja. What's it called?
Okay, when
there's
when
one,
is your clinic day?
Adeni, I think it's Adeni Jones.
Yes, Adeni Jones. When is your clinic day?
Every first week. Hello?
Is it a Monday or Tuesday or Wednesday?
Every first week in the month. Every first week on Monday. I go on Monday. Or sometimes I go on Wednesday if I'm not chance
hello.
at work.
You come in on Monday or Tuesday and see me. Okay?
Okay, sir. But
Tuesday,
what other days can I see you? Because I need to go to work on Monday. I didn't take permission. I'm relieving 2 of my colleagues. So is there any other day I can come?
What on Tuesday? Tuesday?
Okay, I'll speak with my boss and try to call. I'll come on Tuesday. What time is fine by you, sir?
Come in 2:30 p.m. on Thursday. I will give you that grace to see me.
Okay, no, I'll try to come on Tuesday.
Awesome,
I'll make sure I come on Tuesday.
Awesome.
Yeah.
Awesome.
So what time on Tuesday, sir?
2:30. No, Tuesday, 9 to 3. I'm on ground.
Okay. All right, so I'll do that. Thank you so much, sir.
Okay, you're welcome. Okay. Somebody asked here, I had discharge and itching 2 days ago. It took 2 days, but I don't feel it anymore. Do I still need a drug for the treatment? No, I always say that vaginal discharges, vaginal infections, cervical infections are very close home. because it's very close to where the baby is and close to the placenta and every other thing there. So we want to really manage infections in that area before it causes preterm contractions, preterm deliveries for us. We don't want that to happen. So I will implore, whether you are having a symptom now or you had a symptom 2 days ago, it was serious, why not come and let them take a swab of the vagina, send it and treat you as the case may be. You don't want it to become serious before you come out again. So please, the person asking the question should do well to come in and let a swab be taken. Okay, somebody said, can I take another dose of malaria prevention drug at 26 weeks? Well, I need to know how many doses you have taken. Okay, how many doses have you taken? If you have not completed your doses, obviously you take another dose 4 weeks apart. Okay, so it's important to know the number of doses you have taken. At 37 weeks, what should I be expecting? I wouldn't know the area of, I wouldn't know what exactly you should be expecting because that is not a specific question. Are you asking about labor symptoms? If there are labor symptoms, usually you want to discuss with your gynecologist, okay, your delivery. Okay, so if you do come here at your next visit in the next 1 week or some days from now, please ask your gynae, what are the labor symptoms I should expect if you're a first-time mother? Okay, so you do ask that. I don't want to go through labor signs and symptoms now, so I wouldn't hold up so many questions. Okay, you need to know what to expect in labor before you pick your box and start coming into the hospital. What are the things you should see? Okay. Somebody asked which vaginal discharge is normal in pregnancy and which is not. A vaginal discharge is not normal if 1, it is malodorous, meaning that it is smelly. 2, it comes with itching. 3, it is discolored. Discolored means yellow, green, brown, cream. So a normal discharge will be white.
Right.
Basically colorless. So you want that to happen. Okay, so those abnormal ones are the ones I've mentioned. Okay, so once you see any of such abnormality, please do come in right away for us to do what? Take a swab, start on antibiotics, and manage that. Okay, sometimes I feel my stomach hard from 23 weeks. You most likely are experiencing what is called a Braxton Hicks contraction. They are preparatory contractions for the labor process at 9 months. Okay, these Braxton Hicks contractions are painless or at most uncomfortable. They are never painful. If you have painful contractions, pain in your abdomen, please come into the hospital, have an examination done, and be reviewed by the doctor. Okay. Okay. Any other question, please? Okay. I think that covers it. Dr. Dogini.
Sir.
Thank you so much. You've done very well. Thank you so much. So in the absence of any other questions, please engage your gynecologist when you come in for antenatal. All those things you may have read online, all those things your parents may have told you, your friends, relatives. When you come to the doctor, it's not about the doctor just talking. Questions. Doc, I read this, I saw this, I read this. What is your opinion? And your doctor, I'm sure, in 2 or 3 minutes, will put the record straight with you. Okay? So thank you so much, everybody. God bless
Thank
you.
you.
So we'll see you again in the next 2 weeks.
Thank you.
Yes,
Thank you.
Yes, you can come to the hospital for a swab today, okay? They will take it. It's easy to take, okay? Thank you so much. Bye.
Thank you.
Bye,
Bye.
doctor. Bye.